Good evening, all of you. On behalf of Kerala IRIA, I welcome all the faculties who are on the platform, especially Dr. Thara, Dr. Aditi, our backbone of today's session, Dr. Amrita, and who's the other PG?
Dr. Shruti Babu.
Dr. Shruti Babu. I welcome them for today's session. Then I welcome all the residents and the faculties who are listening to this session. On behalf of Kerala IRIA, I'm very happy that we are conducting the head and neck sessions, and we have almost covered most of the topics from the month of January till today. So I'm happy that we'll be having the head and neck radiology today, and I give this platform to Thara, who will introduce Dr. Aditi. Over to you, Thara.
Thank you, ma'am. The faculty for today's discussion is Dr. Aditi. She is a radiologist working with us at Lakeshore Hospital, Kochi. She has had an MBBS from Calicut Medical College and her PG from one of the prestigious institutes, SDPGI Lucknow. And she's got a gold medal for her proficiency in community medicine. And she's also got a European Diplomate of Radiology there. She's got a fellowship. She's done her GNP, and she's so passionate about teaching. I welcome you, Aditi, to this session.
Thank you.
I think you can start the session.
Yeah, you can share the screen, Dr. Amrita.
Okay.
Yeah.
Is the screen visible, ma'am?
Yes, sir. Yes.
Good evening to all. I am Dr. Amrita Aravind, PNB resident, Lakeshore Hospital, Kochi. This is a 38-year-old female patient.
One sec, Tara, I'm not able to see the screen.
Even I am not able to, ma'am.
Yeah, Amrita, I think it was visible in the beginning, but now we can't see your slides. Soumya, can you help her?
One moment. You help her?
Yeah. Can you just reshare once again, please?
I have shared the screen, but it's showing your screen post. Your screen sharing is paused.
One moment. Can you try once again now?
Again, I have shared the screen.
There is a network issues. You can switch off your camera and maybe.
Yeah, now it's visible.
Okay, ma'am.
You can start. Make it slide share and start.
This is a 38-year-old female patient who presented with history of swelling over the left side of neck since 3 years and change in voice since past 2 months. Following which an MRI neck was done in a hospital. This is the axial T1 weighted images. Which shows oblated T1 varying signal intensity lesion epicentered in left carotid space. And this is extending from the level of carotid bifurcation, extending up to the skull base. A few flow voids also can be seen within the lesion, T1 hypointense areas. And the lesion is seen completely encasing the carotid bifurcation and left ICA and external carotid arteries. These are the ICA and the ECA left side. And anteromedially, it is displacing the left parapharyngeal space. This is the opposite parapharyngeal space showing the normal fat. And here it is effaced. It is also anteromedially displacing the left pharyngeal wall. Anterolaterally, it is abutting the posterior belly of left digastric and the medial pterygoid muscle. And this is the left IJV, and it is seen laterally compressed and displaced by the lesion. And posteromedially, it is abutting the longest poly muscle and the medial paravertebral muscles. The right carotid space appears normal, no evidence of any focal lesions. Both parotid glands appears normal. Both submandibular glands appears normal. No significant enlarged cervical lymph nodes. This is the diffusion weighted showing predominantly peripheral diffusion restriction. So this is a low signal in the ADC map. That's a peripheral diffusion restriction is seen. This is the axial T2 FS images showing heterogeneous signal intensity areas in the lesion. T2 bright areas are seen with a few flow voids, giving a salt and pepper appearance of the lesion. Few ovoid bilateral level 2 cervical lymph nodes, likely reactive. This is the axial TOF angiogram images. The right and left carotid arteries. And you can clearly see the splaying of the left C and ICA by the lesion and completely encased by the lesion. And within the lesion, predominantly arising from the left ICA. So the neovascularity is seen clearly in this. And the intracranial ICA and middle cerebral arteries were normal. It's the sagittal post-contrast images. showing intense enhancement of the lesion post-contrast. No evidence of any definite infiltration to the adjacent structures. No other focal enhancing lesions. So with these imaging features, diagnosis is a left carotid body tumor, Champlain classification type 3. And the features favoring left carotid body tumor, first one is the splaying of the left internal and external carotid arteries and flow voids within the lesion, giving a salt and pepper appearance and intense post-contrast enhancement. Thank you.
So, okay, Amrita. So that was a good presentation, very crisp and clear presentation. And the case is very straightforward. And I would like to ask you a very few simple questions. So what are the contents of carotid space?
The contents of carotid space include the left carotid artery IJV, then vagus nerve, hypoglossal, glossopharyngeal nerves, sympathetic chain.
So what are the probable lesions that can arise from the carotid space?
In the carotid space, another one is a vagal schwannoma can arise. Then vagal paraganglioma. Then hematoma, carotid aneurysms.
Okay, and then we have lymphatics. So lymph nodal pathology can arise. Then sympathetic chain is there. So sympathetic chain related paragangliomas. Okay. So then what are the other locations of paragangliomas in the head and neck? So where else will you look for multiple lesions?
Multiple lesions.
Other than the carotid body tumor in the head and neck region, which are the other common locations from above downwards?
Laryngeal paraganglioma. Can you?
A few named ones.
Glomus vagal paraganglioma. Organ of Zucker candle.
Where is organ of Zucker candle? I'm asking about head and neck region. So another thing is glomus tympanicus, okay, which is seen in middle ear along the promontory. Then what is the characteristic enhancement features of contrast enhancement features of paraganglioma?
It shows intense post-contrast enhancement.
Can you mention any other lesions which show similar intense enhancement in this location? I mean, in the head and neck region. Because you mentioned schwannoma, other cystic lesions and all. So they almost all the vagal schwannomas, sympathetic schwannomas, all their enhancement is much lesser than is expected for paraganglioma. So if you see another lesion with an intense enhancement, what else will you think of? What other imaging you have to do?
Hypervascular metastasis can cause intense enhancement.
From?
It can be from papillary CA thyroid, most commonly.
Okay. And when will you call a paraganglioma as malignant?
Malignant. If there is infiltration of the adjacent surrounding structures, bony lesions, then
Is it common to see bony lesions in paraganglioma?
It's rare.
So actually it's nodal mets. If you see nodal mets, that is in favor of a malignant thing. Then what is Champlain classification and what is the importance of that?
In Champlain classification, the carotid body tumor is classified into 3 classification. Type 1 is less than 180 degree encasement of the carotid arteries. In type 2 is 180 to 270 degree, and in type 3 is more than 270 or complete encasement of the vessels.
So it
Yeah,
actually
plus-
decides the vascular relation and the surgical prognosis, right? So the type 1 is easily dissectable, and 2 and 3 are difficult to be dissected out from the carotid, and 3 is extremely difficult. Okay, so what additional specific point you have to mention in our report with regard to management of the lesions? As far as the vascular part is concerned.
the length of the ICA, that is
Distal to the tumor.
distal to the
Okay, so what is the significance of that distal ICA stump?
because it can cause complications like infarction or brain ischemia if there is
So in Chamberlain classification, in type 1, there is less than 180. So that can be easily dissected out. For type 2 and type 3, what happens is the lesion encases up to 360 or 270 degree of ICA. So sometimes during the surgery, they may not be able to dissect out the entire tumor from ICA, and they will have to resect ICA and do anastomosis with a graft. Okay, so for the purpose of graft, sometimes we require a distal ICA stump. And that distal ICA stump should be approximately, that is at least there should be a 2 centimeter stump of distal ICA. So the distal ICA available, distal cervical ICA stump available should be mentioned in your report. Okay.
Okay.
So what are the few syndromes associated with carotid body tumor?
Syndromes like MEN2 syndrome, then tuberous sclerosis, neurofibromatosis type 1, VHL, these are.
Okay. Is there any requirement for brain imaging? Or what is the role of brain imaging in, or when does the indication come?
Yes, ma'am. To look for any collateral vessels, if the involved carotid artery is damaged, then collateral supply should be there to prevent the brain from brain ischemia. So
Okay.
look for the vessels.
Okay, vascular supply and the distal ICA status, we have to go for MR brain image. Then what's the role of DSA?
DSA. In DSA, first preoperative embolization can be done during DSA. Also, balloon testing can be done by occluding the opposite ICA and
We look for
collaterals.
Okay. And then what's the sign in angiography known as, that is regarding this playing? What is that sign called?
This playing is called Liar sign.
Okay. And preoperative embolization, what is the advantage of preoperative embolization? Why is it done?
First, it will reduce the bleeding during the surgery. Second, it can also reduce the size of the lesion.
The thing to be noted is that preoperative embolization should be done at least 1 to 2 days before surgery. There should not be much gap between pre-op embolization and surgery, because the lesion will get some time to recruit more vessels. Okay, so that is about. And what is commonly used for preoperative embolization?
Directly can inject the glue into the
glue or gel form or PVA particles. Okay. Okay, so I guess, ma'am, anything to add? Tara ma'am, Gomati ma'am.
I think regarding paragangliomas, we have covered almost everything. And regarding schwannomas, I think we have to take delayed images at 10 or 15 minutes because they show delayed enhancement, and that's a method for differentiating them. I think we'll move on to the next case.
The screen visible, ma'am?
Yes.
The next case. This is a 29-year-old female patient presented with complaints of swelling over right parotid region since 3 years, following which an MRI neck was done. The axial T1 weighted images. Showing a well circumscribed multilobulated T1 hypointense lesion involving the superficial part of right parotid gland. And in the superior aspect, there is mild extension medial to the ramus of mandible. However, the non-definite involvement of the deep lobe of parotid gland. No focal lesions seen in left parotid gland. There is no extension of the lesion into parapharyngeal space. Parapharyngeal fat is preserved. And the masticated space appears normal. No involvement of right carotid or IJV. Both salivary glands, both submandibular salivary glands appears normal. No significant enlarged cervical lymph nodes. This is the axial T2 FS images showing markedly T2 hyperintensity within the lesion. The small ovoid bilateral cervical level 2 lymph nodes are also seen. And this is the diffusion weighted images. There is no evidence of any diffusion restriction. This is the axial post-contrast images showing heterogeneous enhancement of the lesion. No other focal lesions visualized in the opposite parotid gland or submandibular salivary glands. Base of skull appears normal. So the imaging features are suggestive of a benign right parotid gland tumor, possibly a pleomorphic adenoma. Thank you.
So again, that was a simple thing, almost like a spotter. So can you take T2 weighted images, Amrita? T2. Okay, stop there. No, at the lesion. Show me the lesion. Okay. So based on the T2 imaging characteristics, what are the differentials?
So this is a T2 bright signal is seen in the lesion. So T2 hyperintense lesions can be first is a pleomorphic adenoma, and it can also be cystic lesions like branchial cleft cyst or
Which branchial cleft?
first branchial cleft cyst.
Okay.
So it can be a hemangioma also. Since
Okay. So then, what do you think if it's whether it's a benign or malignant lesion?
The lesion is well circumscribed with no infiltration to the surrounding structures. And there is no evidence of any perineural innervation. No thickened nerves are seen in the base of skull. So possibly benign lesion.
Adjacent spaces are all preserved. Deep lobe is not involved. There are no significant morphologically significant nodes in the neck. Okay, so these are few imaging features that favor malignant versus benign. Okay, now based on the enhancement pattern, take post-contrast images. Okay, how will you characterize the lesion based on post-contrast images? Okay, tell me the benign and malignant lesions of parotid.
The benign lesions is pleomorphic adenoma most common, then Wathen's tumor, and hemangioma, lymphangioma, branchial cleft cyst, lipoma.
Okay, what's the difference in enhancement pattern of pleomorphic and Wathen's?
Wathen's tumor usually shows a poor enhancement, whereas good enhancement can be seen pleomorphic adenoma.
Okay. Now, what are the contents of parotid space?
Parotid space, parotid gland with its duct, retromandibular vein, facial nerve, then parotid lymph nodes.
And can you routinely see facial nerve in routine imaging?
Routine imaging is difficult to see. So, for the landmark, we usually draw a line along the lateral border of posterior belly of digastric to the lateral margin of the mandibular condyle.
Okay.
So lateral to this.
Okay. So mostly our lesion is confined to the superficial lobe, right? Then, what are the clinical symptoms of development of malignancy in a parotid lesion?
Parotid lesion it can invade the facial nerve, causing facial nerve palsy.
Okay, facial nerve palsy or enlarged lymph nodes. Or, okay, that's all. Now, what are the advanced MR imaging techniques which helps to differentiate between the benign and malignant lesions of salivary gland?
We can go for dynamic contrast imaging. And
how do you differentiate?
They say after contrast administration, after 120 seconds, a 30% washout highly suggestive of a malignant tumor.
That is time to peak 120 seconds and more than 30% washout. So is there any benign tumor that contradicts this rule?
Wathen's tumor can also
Wathen's tumor many a times follow the imaging features of malignant lesions. Okay, in terms of dynamic contrast enhancement as well as diffusion restriction. Okay, usually most of the malignant lesions show intense diffusion restriction as well as Wathen's tumor, whereas benign tumors have less diffusion restriction. Then, what are if there are multiple lesions and bilaterality? What are the differentials you will consider?
Wathen's tumor can present with bilateral involvement and multiple in older men. Then lymphoma, metastasis, no lymphomas.
Okay. And what about the TNM staging of the lesion for malignant lesions of parotid? Like less than 2, 2 to 4, more than 4, and involvement of skin, subcutaneous tissue, and other structures. So T1, T2, T3, T4. Okay.
Okay.
So T1 is less than 2, next is 2 to 4, then more than 4, and involvement of adjacent structures. And similarly, for all head and neck tumors, nodal staging is like less than 3, 3 to 6, and more than 6. Okay. So that's all regarding the parotid tumor. Tara ma'am, Gomati ma'am, anything to add?
In which parotid lesion has a propensity to involve the nerves? Which lesion spreads along the nerves, Amrita?
Most commonly adenoid cystic carcinoma can cause perineural invasion.
Yes. And then you didn't tell us about the facial nerve involvement, whether you'll be able to identify it on MRI.
On 3 Tesla MRI space imaging can show the facial nerve.
Yeah, good. I think now we are behind time, so I think we'll move on to the next case. And I request Dr. Shruti to start presenting the next case.
Good evening, all. Is the slides visible, ma'am?
Yes.
So moving on to the case, I'm Dr. Shruti Babu, DNB resident, Lakeshore Hospital, Kochi. And this is my first case. This was a 51-year-old male patient who was a renal allograft recipient and a non-diabetic patient with a recent history of COVID infection. He developed acute onset of slurring of speech associated with generalized weakness and fever. So on examination, there were global aphasia, right hemiplegia with right UMN facial palsy. And we have done a plain CT brain for this patient. And the plain CT, the axial images show ill-defined hypodense area involving the right left anterior frontal lobe. Also, there was ill-defined hypodense area involving the left gangliocapsular region. At the level of the paranasal sinuses, there were opacified mucosal thickening involving bilateral maxillary sinuses, ethmoid sinuses, and sphenoid sinuses. And the bone window showed minimal thickening of the left maxillary sinus wall, posterior wall of left maxillary sinus compared to the right. And this is a bilateral cribriform plates, seems to be intact. No obvious evidence of any erosion seen. For this patient, MRI brain was done. And this is sagittal T1 weighted images showing T1 hypointense lesion involving the anterior frontal and the gangliocapsular region. T2 axial image showing heterogeneously hyperintense lesion involving left anterior frontal and gangliocapsular region. And this is a flare image showing heterogeneously hyperintense lesion involving left anterior frontal and gangliocapsular region with mass effect, focal mass effect in the form of effacement of ipsilateral sulci and compression and effacement of ipsilateral frontal horn of ipsilateral lateral ventricle. No evidence of any midline shift. So these are the axial T2 weighted images. Here we can see the paranasal sinuses, that is bilateral maxillary sinuses show mucosal thickening. Also bilateral ethmoid sinuses and sphenoid sinuses and frontal sinus also show mucosal thickening. In the nasal cavity also, there is mucosal thickening with bubbly secretions. At the level of brain, there is heterogeneously hyperintense area involving the left frontal and left gangliocapsular region with a mass effect as I described. There is no evidence of any midline shift. These were the diffusion weighted images showing high signal intensity areas within the above described frontal, left frontal and gangliocapsular region in the caudate lobe, caudate nucleus. So in the ADC map, those high signal intensity area on DWI show low signal area, low signal intensity, suggestive of diffusion restriction. This is one corresponding image showing diffusion restriction area, patchy areas of diffusion restriction within the left frontal lobe and gangliocapsular region. And this is the SWI gradient sequence showing blooming artifact suggestive of microbleeds within the left anterior frontal lobe lesion. And this was a post-contrast axial even weighted images. So in bilateral maxillary sinus, we can see the mucosal thickening show peripheral enhancement with non-enhancing contents. Similar enhancement is also noted in sphenoid and posterior cells. And there is a central non-enhancing area noted within the ethmoid cells and nasal septum. The anterior frontal lobe lesion show irregular thick ring-like enhancement with non-enhancing central core. In the left gangliocapsular area also showed patchy areas of enhancement more towards the periphery and some non-enhancing areas. There is also subjacent leptomeningeal thickening and enhancement. These are coronal T1 weighted post-contrast images. In this, we can see the non-enhancing central area in the involving the nasal septum and ethmoid sinuses seen continuous with the left anterior frontal lobe lesion, non-enhancing part. These are the sagittal emperage images. Here also we can see the non-enhancing lesion with peripheral rim enhancement. Cerebral dural sinuses show normal opacification, no evidence of any fielding defect, and flowers in T2 weighted images, flowers were also seen normally. This is the actual image showing the enhancement pattern of the paranasal sinuses, and this is a central non-enhancing area involving the nasal septum and ethmoid hair cells. This static image, coronal image showing continuation of the paranasal sinus non-enhancing area and the brain lesion in left anterior frontal lobe. This is called the black turbinate sign. So considering the clinical history, that is with a history of immunocompromised state, development of acute neurological deficit, the imaging features are suggestive of meningitis with cerebritis in left anterior frontal lobe and deep gray nucleus with axis formation, early axis formation. Due to the presence of black turbinate sign and other involvement of other sinuses pointing towards a contiguous spread of infection from the infected sinus. So the presence of the diagnosis of fungal etiology to be considered. This is of acute invasive type. And the CSF findings were normal for this patient. And on function endoscopic sinus surgery, the intraoral findings were pus in all peripheral nerve system paranasal sinuses, necrotic tissue in right posterior ethmoids, and histopath showed gram-negative bacilli and presence of fungal hyphae, necrotizing granulomatous inflammation with a fungal infiltration. And the fungus identified were mucormycosis. So this was a case of mucormycosis with cerebritis, cerebral abscess formation. Thank you.
So, okay, Shruti, so it's a proven case of angioinvasive mucormycosis. And now a few questions. Before going to our case, I would like to know how a CTPNS is done. Few basic questions.
Thin sections. Sorry, ma'am.
What is the protocol for CTPNS? How do we acquire CTPNS?
Thin bony sections.
The sections are, what is the thickness of sections? In 64 slice onwards, the collimation is usually kept at 0.625 mm. Okay, then they send the bony and soft tissue algorithms, and we have to separately image both. I mean, we have to separately assess both the bony and soft tissue algorithm. Okay, then what? Then what? How will you differentiate between bacterial and fungal sinusitis? I mean, what are the basic few? We can't really differentiate, but then few features that favor. This is fungal, this is bacterial.
Sinusitis or brain infection?
Sinusitis.
In fungal sinusitis, there will be on post-contrast necrotic contents, non-enhancing components will be there. T2 hypointense contents will be there. Favoring fungal.
Why?
Because the metallic deposit, iron deposition, and fungal
heavy metal contents of fungal hyphae.
Yes.
That is responsible for the hyperdense contents in CT and the signal void in T2. And then regarding the sinuses involved.
Maxillary sinuses most commonly involved in bacterial.
So first of all, the clinical scenario: if the patient is immunocompetent, the chances of getting an invasive fungal infection is rare. But then non-invasive fungal infections can occur, right? So what are the non-invasive forms of fungal sinusitis?
Chronic invasive fungal sinusitis.
What are the non-invasive forms of fungal sinusitis?
Mycetoma, fungal mycetoma, and allergic fungal sinusitis.
Okay. So one is that. One is immunocompromised status of the patient. Okay. Second is the involvement of sinuses. If multiple sinuses are involved, it's more likely that it is bacterial in an immunocompetent patient. Whereas in an adult who is immunocompromised, involvement of sphenoid and ethmoid sinuses or a unilaterality is more towards a fungal sinusitis. Okay.
Okay.
Then regarding the what is black turbinate sign?
It is seen in post-contrast even weighted images, the non-enhancing turbinate due to the necrotic material of the fungus. It's known as black turbinate sign. Usually, it is specific for mucormycosis.
Okay, then regarding the brain invasion, which is more common?
Meningitis for smaller fungi due to the easiness of meningeal vascular invasion. Meningitis is more common. For like fungus like
bony invasion, bony erosion, and involvement of dura and brain is more common in fungal infection, angioinvasive fungal infections. So based on the brain findings, how will you differentiate between bacterial and fungal? In
Okay,
other words, how will you differentiate between bacterial and fungal brain abscess?
Okay.
Can you open your case? The contrast images.
Yes, ma'am.
Axial window.
Yes.
Okay. Stay there and now.
So in the fungal brain abscess, we'll get an irregular crenated outer wall, rim of the abscess with papillary projections. And this papillary projection may not show contrast enhancement.
What are the papillary projections actually?
They are the fungal hyphae.
Okay. To resist the host immune system. Okay.
Then in bacteria, there will be smooth thin wall with restricted diffusion within the central core and peripheral rim enhancement in post-contrast imaging. Peripheral smooth round enhancement.
And then hemorrhage or an infarction is more common
In fungal.
Okay. Now, will you proceed with CT contrast in every case of PNS? CT PNS I'm asking about. So just a random question. What is the indication of contrast CT PNS?
If there is any suspicious mass like or any to look for any intracranial invasion or any surrounding periantral.
To look for complications of sinusitis. Okay, like subperiosteal abscess, intraorbital, intracranial invasion. To look for vascular involvement. Okay.
Yes.
So, anything more to be added in our case? And take your diffusion images. Okay. So, in these, we can see predominantly peripheral hyperintensity. And what go to AD? There are few specks of hyperintensity along the margins of basal ganglia caudate. So, what do they represent actually? Since we have diagnosed it to be fungal, are we expecting that central core of diffusion restriction in fungal abscess?
Usually the periphery will restrict in fungal.
Okay.
Central and restriction is more common in bacterial pyogenic abscesses. So in this case, the possibility of vasculitis and associated vasculitic impact can be also considered.
Okay, that can be coexisting in our case. Then another thing is fungal cerebritis can restrict like this in some cases. It's not typically seen in every case of fungal abscess, but fungal cerebritis in some stages can restrict like this. So in our case, there may be coexisting fungal cerebritis and infarction. Okay. Secondary to vasculitis. Okay, ma'am, anything to be added?
I think we can move on to the last case.
Okay.
Continue with the spotters.
So moving on to the second case. This was a 47-year-old gentleman presented with recurrent episodes of epistasis. So MRI brain plane with contrast was done for this patient. These are the T2 weighted coronal images. So We can see T2 hyperintense lesion involving the roof of bilateral nasal cavity. And ethmoid sinuses. And there is invasion of cribriform plate, and the lesion is extending into the anterior cranial fossa bilaterally. There is buckling of bilateral gyrus recti. The CSF cleft is seen here, but at some places, there is loss of the normal CSF cleft between the tumor and brain parenchyma. Also, the tumor is seen invading, abutting the bilateral middle terminal and is also extending into the right osteomeatal complex unit and with the resultant mucosal thickening of the right maxillary sinus. It is also involving bilateral frontoethmoid recess with mucosal thickening of bilateral frontal sinuses. Posteriorly, the lesion is also involving the bilateral sphenoethmoid recess with mucosal thickening involving bilateral sphenoid sinuses. We can see the flavoids of in the internal cerebral and middle cerebral, internal carotid artery, middle cerebral arteries bilaterally. The other T1 weighted sagittal images showing predominantly T1 hypointense lesion involving the roof of nasal cavity bilaterally with anterocranial fossa invasion. So it's a diffusion weighted images showing areas of restriction within the lesion. There's anterior cranial fossa involvement also showing diffusion restriction. Post-contrast hemorrhage showing intense enhancing lesion. In the nasal cavity, which is extending into the anterior cranial fossa. There is adjacent dural thickening and enhancement. Rest of the brain show no evidence of any abnormal enhancement. All the dural sinuses were seen normally. So also coronal post-contrast images showing intensely enhancing lesion in the roof of bilateral nose and ethmoid sinus with the invasion into the bilateral anterior cranial fossa. At the level of cribriform plate, we can see the vase-like appearance. So in this a patient with a history of epistasis, the imaging features are suggestive of Esthesioneuroblastoma as a first differential and sinonasal carcinoma as my second differential.
Why did you call it esthesioneuroblastoma first?
It is because of the typical location of the tumor. That is, it involves a superior was part of the nasal cavity, superior nasal recess.
Okay, and it is going up through the cribriform plate involving the olfactory fossa.
Yes, ma'am.
Then histopathologically, how will you classify it?
It was the Hyams classification.
No, I mean, histopathologically, this is a small round cell tumor.
Yes, ma'am.
So all differentials of small blue round cell tumors can be differentials of esthesioneuroblastoma. Okay. And then like lymphoma, melanoma, neuroendocrine tumors. And the typical location is characteristic first. And then we have peritumoral cysts and speckled calcification. Both of these features are not seen in our case. And which is a site of, is Mets common? Is it malignant?
Cervical, yes, ma'am. Cervical lymph node mets are the most commonest, and bony liver lung mets can also occur.
Okay, so on follow-up, we should image the neck as well as chest X-ray should be done and bone scanning should be done.
Yes.
Okay,
Yes, ma'am.
and then what are the classification systems?
Initially, we use the Kaddish classification, which involves the stage A is involving the nasal cavity, and stage B is nasal cavity and paranasal sinus. Stage 3 is C is extension beyond the paranasal sinuses into the orbital fat, base of skull, means anterocranial fossa. Then then modified Kaddish added distant metastasis cervical lymph nodal mets.
Okay, so
Then there is TNM also, TNM classification also.
Okay.
That is what we follow now. Do I need to explain?
Pardon?
TNM classification, do I need to explain?
You can show the slides if you have.
Okay, okay. So this was the TNM classification. In T1, there is involvement of nasal cavity or paranasal sinuses without involvement of sphenoid and superiormost ethmoid. Then T2 classification, T1 plus involvement of sphenoid sinus or extension into the superiormost ethmoid or erosion of cribriform plates. And in T3, it extends into the orbit and anterior cranial fossa without dural invasion. In T4, there is involvement of brain. In our case, the dura is there is dural enhancement and
so without dural invasion is T3. So there is dural invasion in our case. So it became T4.
T4, yes, ma'am.
Okay. So that's all.
Thank you.
So can we move on to the spot test now?
Can you see my screen?
Yes, Aditi.
So I have 16 spotters. First stage will be done by Amrita and next by Shruti. All answers will be discussed at the end. Amrita?
Axial CT image.
No, just mention the diagnosis.
Fibrous dysplasia.
Where?
Involving the left sphenoid bone and maxillary.
Can you see anything else? Okay, we'll move to next case.
Posterior, the choana is obliterated.
Yeah, correct.
Choanal atresia.
Choanal atresia. Do you know any syndromes associated with choanal atresia? Okay, we'll discuss that. Next. Amrita?
Yes, ma'am. There is widening of the prevertebral space involved.
What are
Okay.
the diagnosis straight away?
Retropharyngeal abscess.
Correct.
Chronic hemorrhage.
Okay. B.
Huh?
Any differential?
Uh,
If it's a soft tissue lesion,
Choroid melanoma.
then
Then retinoblastoma.
okay. Sorry, this is actually USG neck. Okay. What is the appearance called and what is this?
Which part, ma'am? Neck.
Neck.
Neck. Dermolysis.
Correct.
Venous malformation.
Where is the location?
Involving the left nasal cavity and guana and sphenoid sinus.
So can you think of any sinus pathology? Amrita, are you there?
Ma'am.
So this is going to be a last case. Isn't it, Aditi?
Yes, ma'am. Okay, Amrita, any idea? You can describe the findings if you want, and then don't worry, it's a tough case.
The right carotid artery is obliterated.
Okay.
Internal carotid artery is obliterated. Then there's a posterior fossa cystic lesion.
Okay.
Deformity of the chest wall.
So we'll discuss all the cases at the end, right? We'll go to the next candidate. Shruti.
Would you just give your diagnosis? You need not describe the findings.
Sinonasal carcinoma.
Can you describe the finding? I mean, the typical appearance of this. What is the typical appearance called?
Inverted papilloma.
Okay. Appearance is called?
Cerebriform appearance.
Okay.
Bilateral optic nervous edema, optic neuritis.
Pardon? Bilateral?
Optic, optic neuritis, nerve sheath,
Differentials?
meningiomas,
Then?
gliomas,
Associations?
neurofibrin, NF1,
Okay.
IJV, thrombosed, right IJV is thrombosed.
Okay.
The septum means there is walled cavity.
Okay. How will you link both the findings?
And septic embolism.
Okay. Is there any name for the syndrome?
Lemierre.
Correct.
Carotid. Livus.
What is the location? What is the location of the lesion?
Part of clivus. Epiangle. Osteosarcoma of mandible.
Correct.
Dendrigerous cyst.
Association? Okay.
Abscess in the right left around
Left?
tonsillar portion.
Okay.
Parotid, right parotid.
What is that?
Branchial cyst. Neoplastic lesion involving the or of nasopharynx. Maxillary mastoid. This also appears specified.
Okay, so that's it. So, okay, good. So that is, so we'll go to discussion. So this is a case of choanal atresia. So how can you call it choanal atresia? So at this level, that is the posterior most aspect of the nasal cavity, there is obliteration. Okay, so if this measurement, usually the measurement is done at the level of pterygoid plates. If this measurement is less than 3 mm, it can be called choanal atresia. And the most common syndrome associated with this, with choanal atresia is Charge syndrome. So in this case, we can see coloboma. Here we can see abonicoannular atresia. Here there is cardiomegaly. So what are the components of Church syndrome, Amrita? Okay.
Coloboma, cardiomegaly, and coronary atresia.
And Church. Rest of the components? Hemangioma. Hemangioma. So Charge, CHARG. So C for coloboma, H for hemangioma. Hemangioma should be a segmental hemangioma, or at least 5 centimeter hemangioma is required to characterize it as Charge syndrome. Okay. Then we have growth retardation, genitourinary abnormalities, and ear abnormalities to call it Charge. And do you know any teratogenic drugs which can cause Charge syndrome? So antithyroid drugs in pregnancy, in early pregnancy, is known to cause Charge syndrome, has an association with Charge syndrome. Okay. Now you are right, this is retropharyngeal abscess. So Amrita, what is the normal measurement of prevertebral space in X-ray? Then do you call prevertebral spaces widened?
Normally, it should be almost equal to the width of the vertebral bodies.
Is there any specific value for that in adults? So usually at the C2 level, it is 6 mm. At the C6 level, it is 22 mm. So any value more than that will be considered as widening of prevertebral space. Okay.
Okay.
What are the other DDs for retropharyngeal abscess? Here we have air foci also. So it's more in favor of an abscess. So other causes of widening of prevertebral space?
Retropharyngeal hematoma can cause.
Okay.
Then a tumor in the retropharyngeal space.
Okay. So this is the retropharyngeal abscess CT. So while reporting CT, we have to look for the airway compromise. We have to comment on the adjacent vascular status, and it can also cause spondylodiscitis. So we have to comment on the epidural component. Okay, it's a surgical emergency. Now this is retinoblastoma. And what is trilateral retinoblastoma, and what are the other locations of retinoblastoma?
Plus, trilateral means both bilateral involvement and along with pineal gland also involved.
And another region of involvement other than eyes, orbits, and pineal gland? Also look at the suprasellar regions. Okay. Then this is the characteristic sack of marble appearance. And what are the marbles made of? What are these round echogenic things? Fat globules. Correct. Okay, this was a case of frontoethmoid mucocele. And mucocele, because of some obstruction in the drainage pathways, mucus accumulates and they form mucocele. And nearest DD is an encephalomenincocele. So we have to comment on the bone as well as the intactness of the dura. Okay, so that is the importance of frontoethmoid mucocele. Then the nearest DD is meningoencephalocele. Okay, that was a case of Faces syndrome. So here we have a posterior fossa malformation. And then here we have arterial malformation. Here we have a sternal clefting. Okay, then associated. So we have a cardiac anomalies and ocular anomalies to complete the Faces syndrome. Okay. Then that was inverted papilloma. We have the typical convoluted cerebriform appearance. It's mostly it is described in T2 weighted images and contrast images. Okay. And it's a nearest DD of Shruti. What is the nearest DD of inverted papilloma? Does it have malignant potential?
Yes, ma'am. It has malignant potential. Esthesioneuroblastoma.
For this. Sinonasal carcinoma. Then this was a case of bilateral optic glioma, and it's a part of NF1. Okay, and bilateral, how will you differentiate between optic glioma and meningioma? Shruti?
Syndric involvement will be more in meningioma. Ramtraxine will be in meningioma.
Okay. What about the bones?
Hyperostosis in meningioma.
Okay,
And,
and this kinking and tortuosity is more common in optic glioma.
Yes.
Okay. So that was correct. That was a tough diagnosis actually, Lemire syndrome. So here the patient will be having some tonsillitis or pharyngitis initially, and they go on to develop IJV thrombus. From there, they will develop septicemia, and the patient will have septic emboli. Most common site of septic emboli is lung. And also secondarily, meningitis can also happen. So whenever you see a complicated case of tonsillitis or pharyngitis, always look for IJV thrombus, always image lungs as well as brain. Okay. So that was a case of cholesterol granuloma. The lesion is involving petrous apex. So in T1 weighted images, it is bright. It is T2 heterogeneous, and there is no diffusion restriction, and there is widening. It's more of remodeling of the bone. Okay, so this constellation of findings is more in favor of cholesterol granuloma, and the nearest DD is?
Yes,
No.
Cholesteatoma.
Cholesteatomas, yeah. In cholesteatoma, it will be T1 hypo. Actually, it's a diffusion restriction that differentiates between the both. And there is a need to differentiate between both cholesterol granuloma and cholesteatoma, because cholesteatoma needs surgical clearance. Okay. Then this is a typical case of mandibular osteosarcoma. And dentigerous cyst, what are the other odontogenic cysts of mandible? And why did you call it a dentigerous cyst?
An erupted tooth is seen at the
Okay, the crown of the tooth is associated with the lytic lesion. What if the root? What if the lytic lesion is seen along the root of the
radicular or periapical cyst?
And also odontogenic keratocyst. Okay, this odontogenic keratocyst and dentigerous cysts have some common association, like multiple OKCs, most commonly odontogenic keratosis. So multiple OKCs are seen in Name syndrome.
Basal cell Neva syndrome.
Correct. So this was peritonsillar abscess. So how will you differentiate between peritonsillar and tonsillar abscess?
Displacement of the
Okay, peritonsillar abscess usually goes beyond the tonsillar capsule. It goes up to midline. It can cause airway compromise. And there is always a need to drain the peritonsillar abscess along with IV antibiotics. So that is the importance of differentiating peritonsillar abscess from tonsillar abscess. Tonsillar abscess usually settles with IV antibiotic. Now this was a case of branchial cyst. Which type of branchial cyst it is? Shruti?
And second branchial.
Okay, second branchial cyst. So this was an esophageal carcinoma with unilateral mastoiditis. This is just to you have to be sure that in an adult with a unilateral mastoiditis, always look at the nasopharynx. Should never miss a case of nasopharyngeal pathology in a patient with an adult with unilateral mastoiditis. Okay, so that's all.
Thank you, ma'am.
That was an excellent session, Dr. Aditi, the images were so crisp and they were beautiful, and then I am sure that the PGs are benefited. And I thank you so much for the excellent conduct of sessions. So I thank the organizers for making the session possible. And I thank the MedPiper team for the smooth conduct of session. And I thank each and every one of you who have attended the session. Gomadi madam, are you online?
Yeah. I'm online. It was really wonderful, Aditi. The spotters were very good. All exam spotters only, usually kept for the exam. Even some are kept as short cases also. So really wonderful. And the students also did well. I appreciate Amrita and Shruti for doing this wonderful session with Aditi. Thank you so much.